Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Hello, everyone, and welcome to this week's edition of Can COVID Speaker Series. Thanks so much for joining today. My name is Rosa Stalteri, and I lead the knowledge translation team at Can COVID. And I have the pleasure of introducing you to this week's speaker, Dr. Carole Estabrooks, who is a professor and Canada Research Chair in Knowledge Translation in the Care of Older Adults at the College of Health Sciences at the University of Alberta. And our title for today is A Terrible Toll and Stories of Resilience, COVID-19 and Canadian Long-Term Care Workers. So just before we get started, I do want to let you know that we do have a Q&A session. So we welcome all participants to enter in their questions into the chat box at any point during the session today. And we will relay them to Dr. Estabrooks at the Q&A session. Without further ado, I will hand over the mic to Dr. Estabrooks. Thanks so much.
Great. Thank you very much, Rosa. I'm delighted to be here today. And I just fed the cats, hoping they wouldn't torment me, but I see that's not going to work. So you may get bothered by my cats. So I'm going to talk today at a pretty high level about early findings from a study that we've been conducting in Alberta and two other provinces. It's been funded by initially Alberta Health, and then Manitoba and Nova Scotia Health came in a few months later for funding. So those provinces are involved, and also funded in partnership with one of the COVID grants from CIHR. This project happens in the context of our larger program, which is called Translating Research in Eldercare. It's been going about 15 years now. And we're focused on finding practical solutions that contribute to improvements in the quality domains. And today, the work I'm going to be presenting is really focused in the quality of work-life domain as one critical component of improving the lives of older adults, frail, vulnerable older adults in long-term care. I won't talk about this report, which we're currently in early conversations about should it be updated in some way, not sure yet. But except to say that we had a boiling the ocean problem when we did this, and there was just so much to be done from so many years and decades of neglect. And we sat down and had a serious conversation at one meeting and said, if there was only one thing in the entire world, in the entire country, that we would like politicians and governors and policymakers and others to address, what would it be? And it only took us a minute or two to say, oh, the workforce, that it is fundamental to transformative and any other kind of change in long-term care. So that's just a bit of another place that this project fits in terms of the Canadian landscape. It was initially called the Alberta COVID Impact Assessment because Alberta was out early saying, well, it's taking too long to get funding, let's start, and we want these results as soon as you can possibly do them. There are several parts to this project. I'm going to talk today about the early qualitative interviews from last year, but there's been a major modification to our ongoing survey. It's been administered. We've also done quality of life assessments using a subjective quality of life tool, not just a subjective one, actually the DEMQual from the UK, some work on the MDS data. And then a big part of this project is reporting back. This is an IKT, an Integrated Knowledge Translation project, just like our program is. So we made a commitment to the funders that we would report back early and frequently, and before we were ready, because it's been very uncomfortable sometimes for us to report as early as we have. So a lot of the early work has been in camera, embargoed, et cetera, et cetera. We have longstanding relationships with our provinces, with our provincial governments and our stakeholders in the nursing home sector. And so there's this pretty strong bed of trust to build on, and then really focusing on solution-oriented discussions as we go forward. Just a note about survey modification. We normally do the carried part of our surveys in-person structured interviews. So those had to, in a very short time, be converted to Zoom. The quality of life assessments had to be converted to Zoom, et cetera. if you know anything about the long-term care sector, you know that bandwidth and computers and private rooms and all those things are in super short supply. So this was a challenging project to do. I'm not talking about the survey today, but we do have these responses in the green column just cleaned days ago. So we haven't analyzed them yet. We've just looked at some basic distributions and trends as they've come in. And we have an immediate pre-pandemic wave to compare about 2/3 of the survey to. We took it out of the field about 2 weeks before COVID closed nursing homes in early 2020. We have fewer numbers in the COVID wave than we did in the wave 5 because British Columbia is not part of the COVID wave. They weren't able to assemble the funding, so we went without them. Hopefully they'll come back in shortly. A note about the paid workforce in long-term care. Most of you probably know this, but for those unfamiliar, about upwards of 90% of direct care is provided in Canada's nursing homes by unregulated care aides or PSWs or orderlies or nursing assistants. It's an older female racialized workforce that's poorly remunerated, casual, non-benefited positions. About 30% of care aides worked more than one job for financial reasons pre-pandemic. And although we know that quality work life is associated with resident care quality, we know that pre-pandemic care aides in particular reported disturbingly high levels of burnout, job satisfaction, and low participation in decision-making, for example. They also, on the more bright side, also report really high levels of a thing we measure called job efficacy. That's the sense that their work has meaning and importance. And that's probably been really a critical element of their resilience during the pandemic. This is pre-pandemic, pre-COVID data. This is not post-COVID data. I just put this up to illustrate one construct, burnout, how high the risk was for the workers in long-term care before the pandemic started. So the burnout scales are the top two, and the red zones are the percentage of people, whether they're care aides or RNs, et cetera, who are at high risk for burnout. Burnout has personal impact, family impact, and work impact. You feel terrible when you have it. And it's a serious, we often run around talking about, oh, I'm burned out, but real burnout is a non-trivial state to be in. The good news is with those two upper constructs, exhaustion and cynicism, we also measure this efficacy thing. And care aides report like really extreme high levels of efficacy. We don't see this in other groups at all. And that probably buffers, as I said, and might represent some untapped resource, probably resource that was fully exploited during the pandemic. So the interview findings. We did about 100 interviews in a very short period of time, in part to identify the important areas to explore in the survey, and in part to hear their stories. I thought it would be impossible to get this many interviews, but in some homes, the care aides in particular lined up to be interviewed. So there was a pent-up need to tell their story, to be heard and acknowledged. These were difficult interviews. We interviewed from 9 of our Alberta sites that are sampled across strata of size and ownership, and tried to get representation from those strata. And also Alberta Health Services have provided us a COVID impact status that we also tried to sample across low and in particular low, medium, and high COVID impact, and got a reasonable representation. 6 themes emerged from the interviews. Pretty significant care aid distress at the severe distress experienced by residents. Big effects from the one worksite policies, particularly financial. Workload and staffing. There was no home and no person we talked to who wasn't under pretty severe duress in terms of workload and short staffing. Broad mental health and well-being effects. Within the nursing homes, often they talked about communication that was positive, in that managers and others who tried to really make it as good as possible in terms of what was going on. There was a lot of fear early in the pandemic, especially pre-vaccination. Communication coming from the outside in was almost talked about negatively. The kind of metaphor for it is well, it wasn't just a metaphor, it actually happened in most jurisdictions. The Friday afternoon, 3 p.m. medical officer orders that would come down, everybody in the government goes home, and the homes are left with 20 pages of orders to try and sort out and families to deal with. That came up over and over and over again. And then some positive things about coping. So I'm going to now just break out some of those themes and give a few illustrative comments. So resident isolation and decline was the cause of a lot of not just resident distress, but care aid distress. Their routines are disrupted. They had reduced mobility. They had reduced to no interaction with others and certainly family, no outings. They lost their appetites. And there was an increased use of chemical and physical restraints to keep people in their rooms. So there were people in these nursing homes who stayed in their rooms for 3 months with limited contact. And this is an LPN in one site. By the way, we didn't see in the qualitative data differences between the profit, not-for-profit sectors, or much difference between small, medium, and large, and probably didn't have a big enough sample to see some of those things. And a more impact in the higher COVID homes, but not as much as you might think. So I think there was a lot of depression, there was a lot of isolation, pleas, desperate pleas for family to visit. The residents want you to just sit with them for 5 minutes because they're so lonely, and they didn't leave their rooms for 3 months. I would lose my mind. Very illustrative of some of the things that they said to us. Residents couldn't recognize staff. The care aid trust relationship with residents was disrupted. They just couldn't do the basic personal care. Residents felt punished sometimes, and there was quite a bit of talk about the lack of human touch. So here's an example from a care aide. I have a full gown, a full mask, gloves, a shield. He's hard of hearing. I'm trying to have a really, really important conversation. I think this is an LPM that takes a lot of tact. I'm trying to convey that I care. I remember how frustrated I was that day, and he couldn't hear me. So I'm yelling, and it's such like an emotional conversation to have with someone who's at the end of life. So old people in nursing homes have cognitive impairment, sensory losses from hearing and seeing. And so you dress people up in something equivalent to a hazmat suit. They can't hear them, they don't recognize them, and they're afraid. People with dementia need familiarity, constancy, safety, and to be able to see real faces. So this was a piece that I think was underestimated by the world, at least, not the people in long-term care early on and still in long-term care under pandemic conditions, and had a profound impact. Good care in nursing homes is person-centered relational care. It's based on personal relationships, on trust and safety, and that was all disrupted. The staff had a lot of inner conflict from maintaining isolation, from missed and rushed task-oriented care, more task-oriented than usual, disruption of these relationships, conflict between quality of life work and keeping residents safe work. And many of you know that long-term care is quite a risk-aversive sector, so it's that risk aversiveness really showed, and not without merit or warranting, but still had a terrible impact. Residents and families not always consulted. Burnout, here's a manager who said, as soon as this is over, I'm out. And she wasn't the only manager. And importantly, loss of the rituals of grief, mourning, and death. There are important, like nursing homes, a lot of people die in nursing homes because it's basically a one-way street. You go there at the end of life because your care needs have overwhelmed the family and community. And it's unusual to not die there unless you're transferred to a hospital. When people die, those of you who worked in hospital and other care settings, there are rituals around preparation of the body, remembering. handling things with care, interactions with the family. And some homes have walks of honor that you see, well, usually on TV, you see them around donor recipients, but many homes have implemented these kind of rituals. They're important pieces. And these were all disrupted. So grief couldn't occur. It piled up, but it couldn't be processed the way it normally could. In one of the worst hit homes that we talked to, it was a hard week for the interviewers. The care aides mostly talked about toe tags and body bags. That's a really crude and assaultive experience to be having when you're used to long-term relationships and taking great care when people die. And they think of them as their family members, many of these care aides do. These are just other illustrative comments of some of the things that happened. A care aide who said, it's everything. It's like, I'm doing my job, but I can't save anyone. So I feel bad about myself. Like there's nothing I can do to save the resident. Or I feel depressed and stuck. I can't do anything. I just want to stay in bed. She wasn't the only one who talked that way. And the manager who said, there were a few mornings where I came in and I was supposed to have 6 care aides and 2 LPNs. And there was me and 2 care aides to look after 34 people sick with COVID. It was traumatizing. It was the worst experience of my 40 years in nursing. The people you saw on TV and those of you who worked in acute care, cared for in ICUs who were sick with COVID, these old people in nursing homes who had COVID, they were just that sick. They weren't on ventilators and we weren't trying to save their lives. They were that sick. And the care needs were so overwhelming and the care resources so limited that just that by itself, never mind everything else, was traumatizing for these people. And of course, this is a very emblematic statement for a couple of reasons. Those of you who know nursing know how metaphorically and historically important the Crimean War was in terms of both nursing and epidemiology in the person of Nightingale. And of course, in today's global conflict, it's once again a flashpoint. This is a very moving interview that this came from. There were some silver linings, in particular, greater team cohesiveness. Some other things, but that was the big thing. Here's an LPN who said, in times of trouble where your team comes really close, I think we grew because the team became more close. It showed me that we have it in ourselves to actually deliver good care, even in the worst situations. And we have some brave people who might, just be as brave as soldiers, though they do not carry a gun. Also interesting in our global context. How did they cope? And this is just a tiny snippet because I know I'm coming on near out of time. And we haven't analyzed most of this part of the data, which comes from the survey. They differed by group or what we've seen so far, and it differed by the socioeconomic and cultural context of the group. So for example, managers who have much more purchasing power could have prepared meals brought into their homes, just order them like, Meal Fresh or all those places that you order from. They could hire housekeepers. They could crank the housekeeping support they hired up. They could purchase psychological services. And care aides who didn't have that kind of purchasing power and may not have gone there anyway because of their social and cultural context, gravitated toward the work family, the team, cohesiveness and support, the actual family, and in very significant ways to their particular community, wherever it was, and a lot more discussion about the support that their faith communities brought them than I might have expected. So very different coping strategies. What nobody used and haven't been using in my 40 years in nursing are employee assistance programs. They are not working. They aren't designed to work. They're designed to, I'm going to be really cynical now. They're designed to be the least expensive way to provide the minimally required support. So what could we do? What are some modifiable things we could do? And I just want to leave with this sentiment. We could redesign employee assistance programs so that they worked. But to do that, we have to co-design. So for example, this is from the Alberta survey data. This is all the survey data I'm presenting today. We know that 17% of the care aid workforce is white, and 70% of them speak English as a second language. So obviously, if we're going to design employee assistance programs to meet the diverse heterogeneous needs of the care aid population, we need to have representation in the co-design process from them. And we need to have some input from trauma research informed mental health people. The trauma research world has blown open in the last 15 years, or getting it out to people has blown open. And we know now, we knew post 9/11 in New York City that when they went back 3 years later, they didn't go to their psychoanalyst that the insurance agency said they'd cover or to get CBT. They did things on their own, like dance and yoga and theater and exercise and community group orientated things that help them regulate and calm their nervous systems and heal the traumatic stress injuries to their brains, because traumatic stress is not a mind problem, it's a problem of brain and nervous system. And there's a huge emerging amount of research on body oriented therapies. So mindfulness would be an example. But we shouldn't just say, well, mindfulness will fix it. And so let's put expensive mindfulness programs in as our only option. We need an array of options for different groups. I could go on, but I'm going to stop there because my time's up and open it up to questions. And thank you very much for your patience and listening.
Thank you so much, Dr. Estabrooks. What an eye-opening presentation. And just want to share what someone wrote in the chat box here. That they value the direct quotes, and you can feel the emotion behind some of the quotes here. So thanks for sharing those with us today. So I'll start off with the first question. Sorry, just went away from me. So how has the pandemic shaped the future of long-term care? For example, are there changes in staffing, physical environments of long-term care homes, or long-term care related policies that will continue to exist beyond the pandemic?
Oh, it's a big one. We don't know yet how it's changed it. There have been some changes. For example, out here, they've eliminated 4-bed rooms because that wasn't such a smart idea for infection control and management, and probably not very smart idea for how we want to live as we're older. So, and there've been some infection control changes. There's a lot of work going into thinking about new capital construction and retrofitting. Those are really important. Those are not the fundamental transformative changes that we need. We need them in how we run homes, how we staff them, how we train people, how we treat residents, how we treat staff and family in terms of making these places homes, not nursing homes, not little auxiliary chronic hospitals. So the jury's out on that. Many provinces have done reports. We'll see how, so for example, provinces are saying, we're going to do 4 hours of care. We're going to do 4.5. We're going to do 4.1. 4.1, by the way, which is what everybody quotes, is a number from the United States that's 22 years old. So we might want to think that, and populations have changed, that that's an inadequate number. But the jury's out on what's going to happen legislatively and from a regulatory point of view and from a training, et cetera, point of view. The jury's out on whether there's going to be a safe long-term care act in Canada and what that might mean. The jury's out on whether the federal provincial jurisdictional tensions will be put aside to make change. The jury's out on how provinces are going to react to the new long-term care standards. So there's a lot we don't know yet. And there's a window that will not remain open indefinitely because, you know, we've got a European war now to crowd out the media, and we've got inflation and we've got high gas prices. So the window's still open for long-term care, but we have to move as expeditiously as we can to keep pressing on it so that we get true change if we think that we should treat our older adults the way we would like to be treated.
Absolutely. So our next question here is, Ontario is not part of this wonderful study. Trek focused on the prairie provinces, but I see Nova Scotia was lucky to be included. What needs to happen to make it easier to include more provinces in pan-Canadian long-term care research?
Oh, there's a long answer required, but I can give a short one. Most of our funding is we're partnered, so we have a combination of peer-reviewed funding and government or regional funding, usually government funding. So Alberta and Manitoba and Nova Scotia are in because their governments funded a good part of the study. British Columbia was not able, so they weren't in. So it's about being willing to put some skin in the game and be interested in kind of longitudinal work. That's part of it. And then part of it's just bringing people, email me if you're really interested and you're a researcher or want to. I want to say one more thing about funding. It is extremely difficult to get longitudinal funding for this program. You can get funding for projects like this one, but to get the base funding that keeps the cohort together, think of the Framingham study, Canadian longitudinal study on aging. Those all had some basic platform funding to kind of do the business of managing the data and managing communications and relationships. So that has not been something that CIHR has shown a lot of interest in. Early on in its evolution, it seemed to be more interested, but it's not alone. In every longitudinal program has challenges in this way. But so if it were not for provincial funding, we would not have been able to sustain ourselves for the last 15 years. And as a result of the provincial funding and our relationships with them, we're very applied and we do our best to keep doing strong science, but to also be responsive to end users and funders in terms of what they need, even when it's uncomfortable for us. And believe me, there are times when I just shiver because I think, oh my Lord, we're not ready. We haven't analyzed these data enough. And then the decision makers, the policymakers will say to me, well, we're going to make this decision by Tuesday and we'll make it whether or not you share with us what you have. So whatever you share will be better than sharing nothing. So that guides me a lot. But so there's not an easy question. Email me if you're really interested, but it requires provincial ministries. I think it's mostly a ministerial level thing to be interested. And then we can often get partnered funding from other jurisdictions, from other funders.
So our next question here is, how can the government and policymakers support long-term care workers' mental health during the pandemic?
If there were enough workers being properly remunerated and receiving proper benefits, that would be a core, those of us who were brought up on Maslow's hierarchy, a basic physiological bottom of the pyramid need. It's hard to give psychological, no, I don't want to cite that, it's going to sound really terrible. But it's hard to do psychological things when you can't breathe or you're not circulating your blood or you haven't got enough food to eat. So we need to get proper staffing in place. If you've got 44 sick people with COVID and you've got 2 care aides, it's impossible to plan for mental health. However, if we could stabilize that, then we need to think about listening to them. We need to think about what kind of programs that are reasonably safe in terms of having good enough evidence can we start putting in place. How can we support our managers so that they could support the care aides? Because the managers are getting squeezed. And early peaks that I've taken at the survey data suggest that they're under a more duress than even the qualitative data would suggest. And they're older and they have retirement in their line of sight. So we could have a leadership crisis in long-term care, not careful, over the next 5 to 8 years. So there's a lot of things we need to do, but the first thing we need to do is really work hard. And it's not just about money and hours and benefits. We have to deal with the Canadian crisis in all health human resource planning. There aren't enough workers for health in Canada, and long-term care depends to an extreme degree on immigration to staff its ranks. So we have to deal with supply issues at a national level, I think.
Okay, so we are at 3:30, I will get another question in quickly. So were these workers in a union? So this is referring back to the long-term care workers with the data that you were showing us in quotes. If so, what role did the union play in supporting them? If not, how might a union have helped?
The majority of these workers would have been, but not all of them. I don't have a good answer for how could the union help. I think the unions are really critical players in this. So their job, in a kind of a overgeneralized way, thinking about labor, trade unions in generally, is to hold the line on management and try to secure adequate benefits and remuneration for its members. So I think that job in and of itself is an essential one. Like we wouldn't have maternity leave, whatever we think of unions, we wouldn't have maternity leave in Canada if it wasn't for Cup W. And everybody loves to, dump on Cup W, but they've done a lot of things that we see trickle down into other parts of Canada. So doing their jobs is more important than we might imagine. And I think I see signs that the unions are starting to be more active, have greater advocacy roles. They're trying, from what I can see, to work more collaboratively, especially in the long-term care sector. And it's not just one union. You got the nurses union, and you got if the carries belong to a union, and you've got what the allies belong to. So it's a mix of union environments. So I don't think we need to be hostile, even if we don't think unions are the way to go. I don't think we need to be hostile towards unions. I think we need to embrace them, realize that everybody's got their job and they have a particular job. And when they do that well, it's better for the worker. And when some provinces manage non-union environments a bit better than others, but where there's hostility, we need to get by that, because it's not going to get us anywhere. Unions behave the way they do because they have a job, and we need to bring that role and that membership in. The PSW Association, they're a very important workforce, and where they are unionized, that is an incredibly important component of mom and dad getting good care in nursing homes. So it's not I don't have an easy, quick, short answer to it. And there are others in Canada who do more work with unions than I do, but we would be really egregiously remiss if we did not include unions in conversations. They're important players.
Right. Well, thank you so much, Dr. Estabrooks. There are so many questions still left in the chat box, but we are out of time. So perhaps maybe some folks could email you if they have any lingering questions. Just lots of also great engagement as well.
It's a topic that people feel really, those of us who are older are urgently aware that we might need those services someday. And those of us with moms and dads know that they have or may need those services. So people are personally attached to this when they become aware of some of the challenges that the long-term care sector has. And that's good. That's good for long-term care. We have been quiet too long as a population in Canada about long-term care.
Absolutely. Well, thank you so much, Dr. Estabrooks. We'll end the session here today, but I do want to just say thank you so much on behalf of the CanCOVID team for presenting to us on such important work. And it was definitely an eye-opening presentation. I'm just looking at the chat box here. People are saying such incredibly powerful data. Thank you for doing this important work. And we hope to have you back soon to discuss the other data that you haven't yet released yet. Yeah. So just want to share a few updates here from CanCOVID. Please do join us for the next speaker series, which is on March 22nd from 3 to 3:30. And it will be on the consideration of trade-offs regarding COVID-19 containment measures in the United States. And we also do have another event. It's a CITF event, which is on March 23rd from 11 to 12:30 p.m. Eastern Daylight Time on the importance of pediatric vaccination. Well, this concludes today's event. Thank you all for joining us today and hope to see you at the next one. Thanks again, Dr. Estabrooks.
Great. Thank you.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCovid or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.